Good evening and welcome to Doctors on Call. We're here to take your questions about cholesterol problems and how they relate to heart disease, exercise, and diet. I'm Dr. Ruth Westra from the Department of Family Medicine and Community Health at the University of Minnesota Medical School, Duluth, and I'm your host tonight. Call in your questions locally at 218-788-2844 or toll free at 1-877-307-8762. I'm pleased to welcome this evening's panelists, Dr. Kimberly Boddicker, a cardiologist with Essentia Health, St. Mary's Heart and Vascular Center in Duluth, Dr. Addie Licari, a family medicine physician with St. Luke's P.S. Rudie Medical Clinic in Duluth, and Dr. Jake Powell, an internal medicine specialist with St. Luke's Internal Medicine Associates in Duluth. Medical students answering phones tonight are Ben Doomer from Cambridge, Minnesota, Hayden Kelly of Winona, Minnesota, and Michael Kleja from Bemidji, Minnesota. And now on to tonight's program on cholesterol problems. So we thought when we were talking a little bit that we'd start with some terms because we kind of throw out cholesterol, HDL, LDL, triglycerides. So Dr. Boddicker, could you tell us the difference between HDL and LDL cholesterol?
Well, HDL stands for high-density lipoprotein, so obviously easier to say HDL, and LDL stands for low-density lipoprotein. We need sort of a combination of both to help with various cell function, but HDL typically we call a good cholesterol, and good because it helps sort of extract some of the bad cholesterols out of your body. The LDL, or the bad cholesterol, is usually the cholesterol that is more notorious for causing atherosclerosis or cholesterol plaquing, narrowing of your heart vessels or other vascular disease. So we like to keep the LDL low and the HDL high.
Very helpful. How about values, Dr. Licari? Like a total cholesterol, I know it's hard because we don't know age and things, but what are like some normal values for cholesterol?
So in general, probably less than 200 for the normal person, or around the 200 range for a total cholesterol. We used to have more specific guidelines for LDL, and those things are changing based on more recent guidelines. So it sort of depends on more on risk factors than anything else with the LDL cholesterol. Mm-hmm. Your HDL cholesterol should ideally be above 65. That a higher number is actually a better number for that.
So can we raise or lower it, Dr. Powell? Can we raise our HDL cholesterol?
You can, yeah. So HDL cholesterol, as I like to tell my patients, is much more responsive to to dietary change than the LDL might be. So a diet that's low in saturated fat, high in whole grains, fruits, vegetables, that kind of thing, along with regular exercise, can help to raise your good cholesterol.
So there's another term called triglycerides. Dr. Licari, can you explain that?
So the way I best explain this sort of to my patients is your triglycerides are a transport of dietary fat in your body. And so when you eat that burger or that piece of cheese or something with fat in it, that's what your body uses to sort of transport the fat from your diet coming through your stomach being absorbed in your body. Triglycerides tend to be more influenced actually by diabetic status, by concentrated sugars in the diet such as soda or even beer, and they tend to fluctuate a little bit more. But we do have a link between triglycerides in heart disease. It's less strong, I would say, than the LDL cholesterol, and our values are typically we would treat if they get above 350, 500, higher values.
And men and women both have problems with triglycerides, Dr. Powell?
Absolutely. Both men and women can have trouble with triglycerides. Like Dr. Licari said, there is a big dietary component, genetic component as well. Triglycerides can also cause a condition called pancreatitis when they get over 500, which is kind of one of the absolute thresholds to treat someone with high triglycerides.
Well, Dr. Boddicker, when do we check cholesterol? What age do we check?
Unless there is sort of a familial or family history of severe high cholesterol disorders, so there is some genetic component where you may be inclined to check that in, pre-teen ages or childhood. Most of the time we would recommend in early adulthood, so over age 20, 21, checking that, and then we used to say reassessing that if it's normal, reassessing that every 5 years as an adult, unless you have other risk factors. now the new guidelines have come out and really focusing in on assessing what your 10-year risk of developing atherosclerotic coronary disease. And so the recommendations are similar, checking it around that age, and then every 4 to 6 years, following with your primary physician, having them sort of do a general assessment of what your 10-year risk is. And that risk is calculated based on age and gender, your nationality, and then whether you have diabetes, high blood pressure, smoker, et cetera. So various risk factors, we can calculate out what that risk is.
Well, Dr. Licari, related back to that, we seem to have guidelines, or we do have guidelines for diabetes, and a lot of times we want them to have a lower cholesterol. Can you talk a little bit about that? And
So
we have some
the
questions
guidelines
there.
still for diabetes are ideally your LDL or your bad cholesterol be below 100. Kind of to piggyback off that, if you have heart disease of any kind, we usually like your cholesterol to be at least below 70, if not around 50 for that number. We don't start treating a lot of diabetics until later on in life for cholesterol, unless those numbers are sufficiently elevated or they have other risk factors for coronary disease. So
Very
about age
helpful.
40.
Age 40. Well, Dr. Powell, I have a caller from Duluth asking about BMI, or obesity or weight, and cholesterol and heart disease, and how they relate. That's a pretty big question.
Good question. Yeah, big question. So that's BMI is a term we use, and it stands for body mass index, and it's a formula where we take the patient's height and weight and calculate a number. So the higher the BMI, the generally the heavier the person is, and people who are overweight, generally speaking, have higher risks for heart disease, stroke, high blood pressure, diabetes, and high cholesterol. So being overweight is a risk for a lot of things that kind of play together, specifically related to cholesterol. Not everyone who's overweight has high cholesterol, but it certainly is a more of a marker for someone who may be at risk for high cholesterol.
Caller asking about smoking. Dr. Boddicker, does smoking increase your cholesterol?
I think smoking more lowers your good cholesterol. So it's, you need your good cholesterol to help clear the bad out. And so by lowering that, then you're kind of having a negative effect. And so, we know that, as we talked about earlier, there's the HDL and triglycerides are fairly responsive to lifestyle changes, and one of those being smoking. We know that exercise and quitting smoking, in addition to other health benefits, can raise your HDL or your good cholesterol, and by virtue of doing that, then reduce your overall risk of coronary disease.
Dr. Licari, a caller from Virginia. So probably just some points here about congestive heart failure,
Okay.
and asking if congestive heart failure, if there's any relationship with that with high cholesterol.
I think in general, just as Dr. Powell had discussed, there's a relationship between all of sort of the metabolic things related to congestive heart failure. So typically a congestive heart failure can be caused by a variety of things, including valve disease, but one of the more common is actually hypertension, which plays a role in risk factors for heart disease. But
And I guess I would say that we usually don't treat cholesterol just because you have heart failure. There's not a lot of data to support taking cholesterol medicines if your only diagnosis is heart failure, but we know that the number one cause of most heart failure is coronary disease. So certainly if you have coronary disease or other, risk factors, diabetes, then the link between that is controlling those risk factors will help with your treatment of your heart failure.
Well, let's talk about treatment a little bit. Dr. Powell, I have a question from Duluth about what is the best treatment for cholesterol problems. So maybe we can start with the basics and
Sure.
then continue.
I think most of us would recommend for sure some healthy lifestyle changes first and foremost. Quitting smoking, healthy diet, which we kind of touched on, and regular exercise. But for a lot of people, that's not enough. And we've also mentioned you have to look at the patient as an individual, look at their other risk factors, and decide when to treat. Medical treatment, to be very brief, typically we use a class of drugs called statins, which a lot of people are familiar with. And they've been studied, multiple studies showing all of basically very consistent results that they really help not only lower cholesterol, but also to reduce the risk for stroke and heart attack, which is really what we're interested in. Other medications are available, but their data behind them as far as their risk reduction of those events is much less compelling than the statin drugs.
And people often ask sort of what diet should I be following if I have high cholesterol, and one of the greatest things you can do is maintain a normal BMI, but the other things you can do are increasing polyunsaturated fats and or monounsaturated fats, things found in nuts, things found in plant-based things other than Crisco, saturated fats, butter. Increasing fiber does help pull some cholesterol sort of out of the gut and therefore can reduce cholesterol very mildly. The big studies on diet have in general been able to reduce cholesterol somewhere between 10 and 15%.
So the ads, maybe talk a little bit about the ads about oatmeal or Cheerios, Dr. Licari, maybe Dr. Boddicker. What actually is working when you're having Cheerios, oatmeal, those kinds of things in your diet?
I think
To lower
in
cholesterol?
general, it's the soluble fiber that's sort of
fiber, like you said, pulling out the bad fats, the whole grains. Usually that creates sort of a modest reduction in lowering somewhere, like you said, in the 10% range. Obviously, people who engage in a more healthy diet, of course, may have additional lowering because they're incorporating just general lifestyle changes. So a lot of the benefit is not just from eating the Cheerios or the oatmeal, but the fact that you're being more conscientious about what you're eating and portion control and eating more healthier. So you get benefits, just from beyond that meal.
Mm-hmm. How about risk factors of medicine? Dr. Licari, would you like to start with that one? Caller from Duluth asking about risk factors in taking statins. What are the
I think
problems?
some of the more publicized risks to taking statins are general muscle aches, muscle pains. I think the compounding issue is we usually start treating cholesterol fairly aggressively in middle age and old age when those complaints are very common. There's a rare risk factor or risk of myositis or actual destruction of muscle tissue, and that is very rare, and that is something that is an absolute stop the statin, but that again is very rare. I don't know if you want to speak.
Yeah, I think that's the most common question I get is the side effects, and I think the most notorious or well talked about side effect would be muscle-related side effects, so muscle aches and pains. Again, clearly my patient population, most of them already have coronary disease, and so we're going to have more tendency to push those medications. A lot of those side effects are dose-related. So they can be tolerated at different doses in different patients. There's some that are fat versus water soluble. So again, kind of individualizing per the patient. Everything is sort of how much benefit are you getting from a heart standpoint versus how many risks are you taking. There are some other there's been risks when they first came out about concerns about like liver cancer and liver failure. Those really haven't borne out to be a side effect. There can be some modest increase in blood sugars with some statins. Again, following closely with your doctor, most of these side effects can be sort of attenuated by changing dose or picking the right agent.
Thank you. Well, Dr. Powell, just a couple questions about if you were started on a medication like a statin, what's the follow-up? Like, do we do liver enzymes, or how often would we check people's cholesterols once they're started on medicines?
Generally, I think most of us would want they take several months to really reach full effect, and so I typically will have someone come back in anywhere from 3 to 6 months and recheck after we start medication, recheck their numbers, have them come in fasting, make sure they're working, because they don't work the same in everyone. And the question about the liver function, I think initially most of us would recommend checking a liver function test before we initiate or at the time of initiation, and then maybe once more. But like Dr. Boddicker was saying, really the concerns about the effects on the liver have just not been borne out. In fact, most of the guidelines now do not recommend annual liver monitoring for people on statin drugs. One other point I'd like to make, this is something that happens in my practice all the time. Once we start someone on a cholesterol medicine, they come back, their numbers look great, and they mistakenly stop it thinking, well, I don't need it anymore, my cholesterol is better. Well, of course, what happens is their numbers go right back to where they were before. So it is the kind of thing where if you do stop the medicine, its effects are very temporary, and your numbers will revert to pre-treatment readings.
And it is probably not something that just because you're eating a fatty meal, that's the day you take the medicine, and other days you don't take it. It's something you take every day.
Something you take every day.
Yeah, and I think another important couple points are that cholesterol medications tend to work a little bit better in the evening hours or taken at night because of sort of the way the body functions with regards to producing cholesterol versus taking it from your diet. The other thing is there are certain medications that we tend to monitor a little bit more along with statin therapy. And there are certain dietary recommendations, such as avoiding excess grapefruit juice or grapefruit products with some of the statins.
I think that's very helpful, because I think people are confused sometimes about, taking it at night when you're brushing your teeth or whatever, and kind of wondering why the medicine works better. So I think that was really helpful. So Dr. Boddicker, going back to psyllium or fiber, several questions about that and reducing the cholesterol risk. Is there a certain amount that people should take, or like Metamucil or something like that, or is that not helpful?
That's a good question, and I don't think I have a specified amount. I mean, I think the dietary guidelines would suggest, and actually, Dr. Licari, Dr. Powell may know better, but a certain amount of grams of fiber a day. And if you aren't able to take that in through, what you're eating, then something like Metamucil would be helpful in that. And again, like we talked about, sort of pulling out some of the triglycerides. And so I guess I can't answer a full amount, although, usually when we take it for other dietary reasons, it's usually a tablespoon a day.
Mixed with water, I think.
Yeah.
Dr. Licari, interesting caller from Duluth asking about red rice yeast versus statins. So we probably have seen some people in our practices that have talked about that. Maybe a little conversation about that would be
Yeah,
good.
and I have somewhat little experience with kind of the red rice yeast. I know that I do have some patients who take it. I'm not sure of the overall efficacy. I know there's some side effects too.
I'm pretty sure that it contains the active ingredient is lovastatin, which is when statins were found. Lovastatin is the original statin that was found in nature, and this is where all the other statins kind of have come from. So the red yeast rice has that as its active ingredient. It's a very small amount, but it does. There was some data to support using it. It does lower numbers as far as reducing the bad events, the stroke and heart attack. I don't think there's strong data to support its use for that, but it does. I think it has been shown to lower numbers.
And I think the thing we have to think about with supplements is that they're not regulated by the FDA. We don't know the active ingredients or whether they contain a lot or a little, depending on who you get that from.
Right.
And I think
over the counter.
what Dr. Powell touched on is, I think I have patients who will use some of those supplements when they're intolerant to prescription medication. Because I think there's been some benefit, sort of more natural way of lowering cholesterol. But when we talk about at least prevention of coronary disease, or especially secondary prevention once you've already had an event, we know from the studies that the benefits of the statin classification of drugs goes beyond just lowering your cholesterol. And so, the large randomized trials suggested decreased events, decreased stroke, decreased heart attack, decreased need for recurrent stenting or revascularization. Those benefits came irregardless of what their cholesterol level actually was. So even patients who had what we would typically consider normal cholesterol or low cholesterol actually received those benefits. And so when we're talking about secondary prevention of coronary disease and supplements, you're not getting some of that additional benefit that you may get with the medicines that we prescribe. Yes. In addition, they're not regulated, so it's kind of hard to know, are you taking the right amount, the wrong amount? Is there some side effects that could come from that?
Yeah, that's very helpful. Dr. Powell, a question from Duluth asking about CRP. If that's a better indicator than cholesterol for heart disease.
High sensitivity CRP has been shown to be more of a prognostic factor for someone who you may be on the fence about whether you should treat them with a medication. There isn't really any data to suggest that lowering your CRP prevents stroke and heart attack, but we can at times use it. I very rarely check it. I don't find that it changes my approach very often, but occasionally you'll check it. If there's a patient you're on the fence about, if they have a high sensitive CRP, that's a sign of inflammation, and we think there's probably some correlation between inflammation in the blood vessels and someone's individual risk for stroke and heart attack in conjunction with their cholesterol. So we use it, at least I do, more as an add-on at times if I'm not sure how to treat a patient or whether I should put a patient on cholesterol medication. Thank
you. So Dr. Boddicker, a caller from Wisconsin asking about the guidelines. So this is a caller asking if there's a place on the internet that they can go to about the guidelines, or how do we stay up to date would probably be helpful too.
Well, as a cardiologist, and we put out our guidelines or come out from the American College of Cardiology. That's usually in conjunction with other professional medical groups. And that information can be found on the internet. Usually if you go to the American College of Cardiology and basically Google search cholesterol guidelines. But those guidelines are usually based on a kind of an expert consensus. They review all the data that's been published regarding those guidelines, and then you get a panel of professionals from various groups and put those together. So they are available out there. They're published, but usually in sort of medical peer review. So sometimes it might be hard to obtain that, but you can pretty much Google search anything. But those actually just changed, really, and in regards to really trying to keep treatment in line with what those patient populations who got the most benefit from studies, and really have honed in or narrowed it into really 4 classification of patients. And those are patients who've actually had coronary disease, patients who are at high risk because their LDL or their bad cholesterol is greater than 190, and then patients with diabetes whose cholesterol may be less than 190, and then patients whose lifetime risk of coronary disease is greater than 7.5%. And so taking those things into consideration, there's the guidelines sort of give us guidance on who should actually be treated. So.
Very helpful. Well, Dr. Licari, lots of questions about diet that we're probably not going to get to here, but one about fish oil benefit, efficacy.
Yeah, and I mean, there used to be kind of a large sort of group of people who really thought that fish oil had very, generous benefits for cholesterol, heart disease risks. And really, I think what we're finding sort of in the long term is the benefits for hypertriglyceridemia are there. There's some modest benefit with HDL, but some of the effect on LDL cholesterol really isn't there. And those studies were done on people taking at least 2 to 3 grams of fish oil a day, so at least 2 to 3 capsules of the fish oil a day.
It's a fairly large amount. Dr. Powell, one more question about diet, and this relates to beer, though. It's high cholesterol and beer drinking. Should you stop drinking?
Well, I think most of us would recommend alcohol in moderation, and that's you can take what you mean with that term, but typically that's for women 1 to 2 drinks, for men 2 to 3 drinks a night or less. Heavy alcohol consumption, the biggest effect it has on your cholesterol is raises your triglycerides, and it doesn't have a tremendous effect on your LDL cholesterol, but people who drink heavily will typically have very high triglycerides. In addition to that, it also increases your blood pressure to some degree. So moderation is, of course, important with lots of things in life, and alcohol is certainly one of them.
Yes, thank you, very helpful. Niacin, Dr. Boddicker, any viable reason to use niacin for lowering cholesterol?
So I think Dr. Powell touched on that there's the niacin's biggest benefit is with lowering triglycerides and perhaps modestly elevating your good cholesterol. And so there are situations where you have extreme hypertriglyceridemia at risk for pancreatitis and actually other non-cardiac problems where it's important to lower that. And so something like niacin will be more effective in lowering that perhaps than the statin medications. So there are a few, we used to use it fairly regularly and usually use them in combination with the statin medications, but now that's sort of fallen out of favor because outcomes in regards to reducing coronary events are less, and kind of increased risk of side effects when you combine these medications, but there's still a role, particularly in patients who have very high triglycerides.
Well, thank you all very much. I want to thank our panelists, Dr. Kimberly Boddicker, Dr. Addie Licari, and Dr. Jake Powell, and our medical students, Ben Doomer, Hayden Kelly, and Michael Klaja. Please join Dr. Alan Johns for a program next week on skin problems when his panelists will be Dr. Jeffrey Evanson, Dr. Emily O'Nello, and Dr. Michael Woltz. Thank you for watching. Good night.